All right. Good afternoon, or I guess good morning, still here in Texas. I am Jordan Mayberry, and I am a physician assistant out of Dallas, Texas. And thank you so much again for joining me for a talk today for our MASLD community network. You can use this code, this QR code, to register for today's meeting. And today we're going to be talking about MASLD and MetALD. We're going to start with our patient. So as we move through the slides today, we're going to be keeping Ashley in mind. She is a 52-year-old woman that was referred to our clinic for evaluation. She had an ultrasound that showed mild hepatomegaly and increased hepatic echogenicity consistent with steatosis. Otherwise, she feels well. Her BMI is 29, and again, she's 52 years old. This is a very common patient that comes to our clinic who often had an ultrasound for some other reason and then was found to have hepatic steatosis. So we see her in clinic and we get a detailed medical history. We know she has a diagnosis of PCOS, hypertension, and hyperlipidemia. On physical exam, her liver feels smooth and it's non-tender, and we can palpate that liver edge. Currently, she admits to drinking about 2 glasses of wine per day, and her medications include amlodipine, atorvastatin, she's on a multivitamin, and she is on milk thistle. We get some blood work and we see that her liver enzymes, or ALT and AST, are mildly elevated. Her total bilirubin is 1.2. Her platelets look good at 210,000. She does not have evidence of diabetes with a hemoglobin A1C of 5.9, and her triglycerides are 185. Her blood pressure is a little elevated, and then her overall BMI again is 29.4, so elevated as well. So in our clinic, we're fortunate to have a FibroScan, and so all of our new patients, in addition to having a new patient visit, they will get a FibroScan at the time of presentation. So fortunately, it looks like Ashley had the same, and we can see that her FibroScan results are a little bit concerning. Her FibroScan is an 11.4 kPa, which is consistent with significant fibrosis, so stage 3 fibrosis. And she also has an elevated CAP score. So the CAP score correlates with steatosis in the liver, and her CAP score is 310, which is consistent to severe steatosis. So when we talk about steatotic liver disease, we know that that phrase steatotic liver disease is an umbrella that covers several different etiologies of fat deposition within the liver, or steatosis. Our previous MASLD networks, we talked a lot about this diagnosis of MASLD and MASH, which are related to cardiovascular metabolic risk factors. But what we can see is there is actually a distinct diagnosis of MetALD. And these are our patients that have risk factors for MASLD, but also have increased alcohol intake. And so we can either have patients that have pure MASLD or patients that have pure alcohol-related liver disease, or these patients that kind of fall in the middle that have risk factors for both MASLD and then have increased alcohol intake. So what's really important for us to do is to quantify how much alcohol these patients are drinking. And so when we talk about alcohol intake, it's really important for us to know what is considered a single drink of alcohol. And here is a good table, based on the alcoholic beverage, what is considered a single dosage. So a beer is a 12-ounce regular beer. So whenever we're asking patients, how many beers are you drinking a day? We want to make sure that we are quantifying the ounces. Is this a tall boy, which can be up to 24 ounces? And then also when we're talking about wine, it's 5 fluid ounces. So this is really helpful whenever we are quantifying a standard drink of alcohol. Why that's important is because alcohol and MASH or MASLD appear very similar within the liver tissue. So we know the risk factors for MASLD and MASH include things like insulin resistance, diabetes, elevated BMI, unhealthy food, sedentary lifestyle, and that can lead to steatosis within the liver tissue. Alcohol intake will also cause steatosis within the liver tissue. So both MASLD and alcohol can lead to disruptions in the intestinal microbiome. So this increases ethanol production, increases those lipopolysaccharides, and that can lead to this inflammatory response. So if we have more than one thing causing inflammation within the liver, that can accelerate the fibrosis and accelerate disease progression within the liver tissue. And you can see that here. So you can look at this spectrum of steatotic liver disease here. So you have MASLD, then MetALD, and then ALD. And looking particularly here at MetALD. So we know that fibrosis is a marker of morbidity and mortality within liver disease. So as the fibrosis score increases, the risk for decompensation also increases. So that 5-year risk increases. Once you hit that F3 fibrosis score, that 5-year risk for decompensation increases. But you can see that the risk for decompensation also increases based on the diagnosis. So if we're looking at our patient that has F3 fibrosis, if this was MASLD alone, the 5-year risk would be for decompensation would be between 5 and 15%. But when you add in that second diagnosis, so that MetALD, that risk for decompensation actually increases from 10 to 30%. So fibrosis is an estimate of risk for decompensation, but also the diagnosis also increases that risk for decompensation as well. When we talk about alcohol use here, there is this also tells us kind of the cutoffs for men and women. So when we are talking about MetALD, the cutoffs is anywhere between 20 to 50 grams of alcohol for females and 30 to 60 grams for males. There can also be some genetic risk factors that play a role. We know that NPLA3 is a gene that increases the risk for developing steatosis within the liver and also can increase the risk for developing fibrosis within the liver. So what are some ways that we can detect if a patient is drinking alcohol in excess? Well, if a patient comes to you with evidence of steatosis on ultrasound, we should be considering alcohol as a possible etiology because we know that alcohol can lead to steatosis within the liver, and we know that MASH can also lead to steatosis. So both of those things should be high on the differential when a patient presents to you with steatosis in the liver. We can use things like questionnaires. We can use other testing such as blood testing, urine testing. There is also some hair samplings that we can use to detect alcohol use in this patient population. And then what we know is that 28% of patients that have MASLD also have moderate to excessive alcohol use. So we should be using and optimizing these diagnostic tests to understand, if a patient has MASLD, is it possible that they also have alcohol use disorder or MetALD? There can be some gaps in assessing these patients that have MetALD. So if a patient is coming to you with steatotic liver disease, of course we should be screening them for MASLD alone. Do they have metabolic risk factors? So do they have an elevated BMI? Do they have an elevated fasting glucose? An elevated blood pressure, high triglycerides, or high or low HDL? If a patient has just isolated hypertension and hypertriglycerides, then we should consider evaluating these patients for alcohol use disorder. And we'll talk a little bit in future slides about that association with alcohol and hypertension and alcohol and elevated triglycerides. So if we have a patient that just has isolated hypertension and high triglycerides, we may consider using a PEth test to screen for alcohol use in these patients. We can also use tools like questionnaires to assess for alcohol use in these patients. We should ask about their drinking patterns, how often are they drinking, but also is there binge drinking? And then we can use things like the PEth test, if available, to quantify how much alcohol these patients are using. Again, in women, we should consider around 140 to 350 grams per week. And in men, it should be somewhere between 210 and 420 per week. And that PEth should be somewhere between 25 and 20. And if that PEth is between 25 and 20, and the patient also has metabolic risk factors, that would qualify for a diagnosis of MetALD. So we get a PEth test in Ashley because we are a little bit concerned about her alcohol intake. She admits to drinking 2 glasses of wine. Of course, does that mean she's measuring out that 5 fluid ounces? Or maybe it's a little bit more heavy pour and she may be drinking more than 2 glasses and not realizing that. And so we get a PEth test and we see that her PEth was 120. So that does correlate with moderate to heavy alcohol consumption. If the PEth test is greater than 200, that would correlate with excessive alcohol consumption. So let's talk a little bit about this PEth test. So this is a test that we often use in clinic. I think it's important to be honest with patients when we are, evaluating for their alcohol intake. I never get a PEth test and not discuss with the patient why this test is being used. But the PEth test is able to detect alcohol for 3 to 12 days after a single binge. So if a patient is having increased alcohol intake, it can detect it up to 12 days after that increased alcohol intake. And fortunately, there is no significant variability by sex or BMI. So this is a very good test for us to quantify alcohol intake. I can find that sometimes it's difficult for patients to quantify their alcohol intake and to really talk about their alcohol use. Patients will say, oh, I drink occasionally, or I have a beer here or there, or maybe I have 2 to 3 drinks a week. But when you really try to delve into alcohol intake, patients have a hard time talking about just exactly how much alcohol they are using. And so this can be a helpful test for both the provider, but also to have a discussion with the patient about their alcohol intake and their alcohol levels. Because what we know is that whenever we look at alcohol use in patients that have an elevated BMI, this study took a look at 659 patients that were enrolled, and the inclusion criteria included things like age and BMI, and then exclusion was any other chronic liver disease. So Hep B, Hep C, any previous history of liver disease or a history of HIV infection. And we see that 12 withdrew consent. So overall, we looked at 617 patients. And of those, 284 of them never drank alcohol or there was some data missing. So the in total ended up being 333 patients. And of those patients analyzed, 97% of them had suspected MetALD. So 15% of patients that have excess weight, so an elevated BMI, are likely drinking excess alcohol and are at risk for MetALD. So that's a large percentage of patients that are drinking more alcohol than recommended. When we look back at Ashley's medical history, she has a medical history of PCOS, hypertension, and hyperlipidemia. So if you remember back to that slide when we talked about the gaps in evaluating for MetALD, we know that there is some correlation between alcohol and hypertension and alcohol and hyperlipidemia. So this particular trial looked at the effects of high dose alcohol on blood pressure. And what we know is that alcohol has a biphasic effect on blood pressure. So early, it decreases blood pressure up to 12 hours after consumption. But after that early response, it can increase blood pressure after 13 hours of consumption. So if a patient is drinking alcohol every day, this could certainly cause long-term hypertension. We also know that alcohol affects the triglycerides. So you can see here that with increased alcohol intake, we also see an increase in the triglycerides overall. The graph on the left is comparing alcohol to water. And so you can see that there is not a significant increase in the triglycerides whenever a patient drinks water. But if you compare that to alcohol use, there is a significant increase in triglycerides. So let's go back to Miss Ashley. So she is a 52-year-old woman that was referred for an ultrasound that was consistent with hepatic steatosis. She feels well. We got some blood work on her and she has some mild elevation in her ALT and AST. She's on medication for her blood pressure and her hyperlipidemia. She drinks on average 2 glasses of wine, and we have concern for advanced fibrosis based on her FibroScan. So after doing a full workup and taking a detailed medical history, we diagnose Ashley with MASLD based on her cardiovascular metabolic risk factors. And she has a predominantly MetALD based on her alcohol intake and her PEth levels. So once we have this diagnosis of MASLD, predominantly MetALD, we need to talk about treatment for Ashley. So what are the current treatments? Of course, diet and exercise and weight loss are the mainstay of treatment for MASLD. Ashley is a good candidate for Resmetirom because she has F3 fibrosis. But we really need to counsel her on stopping alcohol intake. We want complete abstinence from alcohol to prevent there from being further damage to the liver tissue, in addition to working on weight loss through diet and exercise and adding Resmetirom. She will need HCC screening because she does have evidence of advanced fibrosis on FibroScan. So we want to make sure that we continue to monitor her every 6 months with an ultrasound and AFP. So as we move forward in our treatment goals for our patients that have been diagnosed for MetALD, and as we continue to study this patient population, I think some of the barriers that are presented to us as providers is we have to overcome this underreporting of alcohol use. Often our patients are not completely honest about their alcohol intake as we are doing our history. We also need to standardize how we assess alcohol use in our patients. And then we need to be able to certify alcohol abstinence. We know that the main drivers of liver disease are those things that cause inflammation within the liver. So does this patient have these cardiometabolic risk factors? And if so, we really need to be more aware of this correlation between, or this relationship between hypertension and hyperlipidemia with alcohol. And after they stop drinking alcohol, do they still need to be on antihypertensives? Are we checking their lipids to see if they improve with alcohol cessation? And then, consider exposure risk factors. How long have they been drinking? How long have they been abstinent? It can take up to 12 months for the body to fully recover from excessive alcohol use. So we want to make sure that at 6 and 12 months, we are assessing, hypertension and hyperlipidemia. So some of the take-home messages today is that alcohol intake beyond 140 grams to 350 grams in women and 210 and 420 in men is considered increased alcohol intake. And if a patient has metabolic risk factors and increased alcohol intake, they do qualify for this diagnosis of MetALD. There should be clinical criteria because we are likely underestimating this diagnosis of MetALD and possibly underdiagnosing alcoholic liver disease as well. So we really should consider using alcohol biomarkers in our workup, such as PEths, to help us understand how much patients are drinking. And then we want to reassess metabolic dysfunction over time. So we should be continuing to follow these patients in assessing their alcohol intake, but also assessing diet, exercise, and weight loss. And then we should consider adequate exposure to risk factors. And then we also know that as clinicians, we need to develop criteria for clinical research to make sure that we are objectively diagnosing MetALD, and this way we can compare different socio and cultural realities for these patient populations. Thank you so much for joining me this afternoon to talk a little bit about this diagnosis of MetALD, and I hope that you consider, this diagnosis in our patients that are coming to us with hepatic steatosis. As always, you can use this QR code to find our community networks in more disease state education.